An important measure of respiratory function is in terms of pressure. The way we measure pressures for respiration is relative to atmospheric pressure, which is about 1,000 centimeters of H2O near sea level. Up here in the mountains at App State, that atmospheric pressure would be a little bit lower. So whenever you look at one of the pressure graphs, like on this image, that 0 is going to indicate atmospheric pressure. When air is at atmospheric pressure, it isn't going to have any reason to want to go anywhere, because the pressure is the same as it would be any place else in the atmosphere. The primary measure of pressure we've talked about for respiration is alveolar pressure, the pressure that's inside the alveoli of the lungs. That pressure is going to be negative during inspiration. Air is going to flow into the lungs to try to return that air to atmospheric pressure. Air outside the lungs has higher pressure. It's going to move toward lower pressure. During expiration, you're going to have positive pressure in the lungs, in the alveolar pressure. Pressure is going to be higher than the pressure outside in the atmosphere, and so as a result, air is going to want to flow out of the lungs to return back to that atmospheric pressure. For quiet tidal breathing, we're talking about a change in pressure from -2 centimeters of water for inspiration to +2 centimeters of water for expiration. If you think about that change in pressure versus the atmospheric pressure, around 1,000, that's a very small amount, a fraction of a percent. The epithelial linings of our airways provide relatively little resistance to airflow, but cases of illness or inflammation in the respiratory passages can provide increased air resistance. Given that we're used to not having to use a lot of pressure to move air around, that can make breathing seemingly very difficult when you're ill, because you have to use a lot more pressure to overcome that resistance. Similarly, the muscular activities that make these relatively small pressure changes can be affected by neurological diseases or degenerative diseases or just aging in general. The graph on this slide shows us different forces affecting pressure on the basis of lung volume. We have 3 different graphs. PI shows pressure that can be generated by inspiratory muscles. PE shows pressure that can be generated by expiratory muscles. And PR is the pressure generated by passive forces. So that would be pressure generated by the alveoli themselves, pressure generated by the costal cartilages, and those pressures are going to vary depending on how full the lungs are. If we first focus on the passive forces, hopefully this curve will make some sense. The vertical axis has the vital capacity going from 0 to 100%, so that represents all of the air that you could possibly move. At 0% vital capacity, you've exhaled all the air you can, and at 100% vital capacity, you've inhaled all the air you can. The resting state for the lungs is around 38% vital capacity. At that resting state of 38%, the pressure generated is 0. The lungs are resting. They don't look to expand or contract, and as a result, they're not going to push any air around. If the vital capacity is less than 38%, then the lungs are squeezed down to smaller than their volume, and they're going to want to return to that resting state. Well, if they're smaller than their volume, they're going to draw air into them to return back to their resting state. Drawing air in takes a negative pressure. So all the pressures of the passive forces when you're below the resting lung volume are negative. If you get above the resting lung volume, all the passive forces are positive. If you're above the resting lung volume, the lungs have been expanded past their resting state. They're going to want to shrink back to their resting state. In order to shrink, they're going to have to push air out. Pushing air out takes a positive pressure. We take the next step and then look at the inspiratory and expiratory muscles, where I've blocked out that passive forces bit of the graph for the moment. Again, hopefully the relationship is relatively intuitive. If we start with the pressures generated by inspiratory muscles, the first thing to notice is that they're all on the negative side of the graph. Inspiratory muscles can only draw air in. To draw air in, you generate negative pressures. On the right side of the graph, we have the expiratory muscles. All the expiratory muscle values are a positive pressure because expiratory muscles push air out, and positive pressure is what's going to push air out of the lungs. Both the inspiratory and the expiratory pressure graphs have a point where the pressure is 0. For the inspiratory muscles, that point is at 100% vital capacity. Once your lungs are at 100% vital capacity, you've filled them as much as you possibly can, and so it's impossible to generate any more negative pressure to bring any more air in. If you could bring more air in, then your vital capacity would be bigger than 100%. Okay, but your vital capacity is what it is, the most air you can bring in. So when that's at 100%, you've inhaled all the air you can inhale, no more negative pressure allowed. Similarly, for the expiratory muscle pressures, that 0 pressure point is down at 0% vital capacity. At 0% vital capacity, your lungs are as empty as you can make them, and so you can no longer generate any positive pressure to push any more air out. If you could, well, then your vital capacity would be bigger. Okay, so those 100% and 0% vital capacity endpoints connect up to 0 pressure points for inspiratory muscles and expiratory muscles. As you move away from those extremes, so as your vital capacity gets closer to 0 for inspiratory muscles, for example, you can generate really big negative pressures. If your lungs are very empty, it's very easy to bring a lot of air in. Similarly, for expiratory muscles, as your lungs get really full, as you get closer to 100% vital capacity, you can generate really big positive expiratory pressures. The more full your lungs are, the easier it is to push a whole bunch of air out of your lungs. On this pressure graph, we have intrapleural pressure indicated, the pressure between the pleural linings that holds the lungs onto the inside of the rib cage and up against the diaphragm. That intrapleural pressure is always negative because it's holding those two linings together, and it's always lower than alveolar pressure, so that the pressure being exerted on the alveoli isn't so strong as to pull the pleural linings away from one another. If intrapleural pressure does somehow get higher than alveolar pressure, the lungs can collapse. I'm not sure of situations where this happens naturally, but certainly with some sort of traumatic injury to the lungs, you can lose intrapleural pressure and have the lungs collapse. There are some other functions related to measuring pressures at different areas. So on this image showing pressures at different locations, there's a subglottal pressure just below the larynx. That pressure is going to be important for laryngeal function and making phonation happen in speech. There is intraoral pressure, pressure within the oral cavity. That pressure is going to be important for making speech sounds in the oral cavity. Things like a s or a t require some pressure in the oral cavity to make noise. Normally during respiration, your subglottal and your intraoral pressures will be the same as your alveolar pressure because while you're breathing, you're not trying to obstruct the airflow either with your larynx or with things in your oral cavity. You can hold the larynx tightly shut. That was thoracic fixation to separate out the alveolar pressure from the other pressures to hold the alveolar pressure constant. This allows air pressure to be an additional support structure for the lungs when doing, say, strenuous lifting.